You can go to the lecture itself. Now, we will talk about a very important, and it is a very important part or problem in the neonatology, which is the neonatal seizure. Because of its high frequency, its high incidence, its a variant presentation, and its important immediate intervention and treatment, and the prognosis that is based on the timing, on presentation, and on the treatment of the neonatal seizure. So we will be learned at the end of lecture to identify the neonatal seizure, its incidence and impact on normal growth and development of a neonate. And we will be able to identify why the neonates are at high risk to develop seizures more than the other age group, and identify the causes of a neonatal seizure, because it's very important and crucial in the management of the seizure. Describe the clinical presentation of neonatal seizure. We say it may be variant, and we will know how to approach the patient with neonatal seizures and manage of the seizure generally and specifically. Now, first we have to define the seizure. What is the seizure in general? What is whether it is neonatal or it can happen at any other age group, especially even it can be defined as it is a brief paroxysmal behavior. So brief, paroxysmal comes in paroxysm, caused by abnormal, excessive, or hypersynchronous neuronal activity of a group of neurons. Or it is abnormal, excessive electrical discharge. That's mean the depolarization of a neuron. Abnormal, excessive, you know, the neuron function is electrical discharge from one neuron to another, which carrying the nerve impulse. So here is abnormal and excessive, causing the seizure. If we talk about the neonatal seizure, so of course we link it to the neonatal period. Again, from the definition, it is abnormal electrical discharge in the CNS of neonates, and it is usually manifested as stereotype muscular activity or autonomic changes. If you know about the seizure, in general, it's causing, of course, muscular activity. But here in neonate, it may cause also autonomic changes. And we will see what are these, the autonomic changes. So, the neonatal seizure duration, to complete the definition, is depending on the gestational age of the baby. So, in the babies, they are full term. It is in the first 4 weeks of life. You know, the definition of neonatal period, it is the first 4 weeks of life. So neonatal seizures in full term baby, it is the seizure that happened in the first 4 weeks of life. But in preterm babies, it's extending to 44-week post-conceptual age because of the prematurity. So if we take an example, neonate born at 30 weeks of gestation. This is mean the neonatal seizure, it is the seizure that happened in the first 14 weeks of life of this baby, because 30 weeks of gestation is real gestational age, and 14 weeks after birth, 14 weeks, it's equal to about 3 months. So in this baby that's born with 30 weeks of gestation, the seizure that happened up to 3 months after birth, it is also regarded as neonatal seizure. Neonatal seizure, it is the most common overt manifestation of neurologic dysfunction in newborn. Neurologic dysfunction may be hemiplegia, paralysis, or weakness, or hypertonia, and seizure. The seizure is the most common overt over these neurologic dysfunction. So, We will talk about the epidemiology. We say there is a high incidence of neonatal seizure, or we say the seizure, it's happened more commonly than any other age group. So, as we said, the seizure more common in neonatal period than other life, and especially in the first week of life, and specifically in the first 12 to 48 hours of life. This is up to 80% of those happened and during this period. So, why the high incidence? This is because the immature brain is seeming to be more prone to develop seizure more than the mature brain. And we will see now during the pathophysiology. So, its incidence in term neonates is about 1.5%, while it's about 20% in preterm neonates. And this increase in the incidence, according to the gestational age, reflecting the problem of immature brain in developing the neonatal seizure. Now we will talk about the pathophysiology of seizure. You know, this is, in this slide, you can see the neurons. Here is the sending neurons. This is the axon, and this is the body of the neuron. And this is the synapses. And from here, this is the chemical signals, or can we say it? We can say it is the neurotransmitter between both neurons, and this is called the receiving neuron. So during this way, the impulses or the electrical discharge, whatever the type of neuron, is transmitted normally in the CNS of the human being. So, what happened in neonatal seizure? We say it is an abnormal excessive electrical discharge or hypersynchronous activation of a group of neurons. Actually, in the mature CNS, we have two types of neurotransmitter. I mean, two groups of neurotransmitter, or two types in its function: excitatory neurotransmitter and inhibitory. So, normally there is a balance between the function of excitatory and inhibitory. But if there is imbalance between the two transmitters, either excessive excitatory or deficient inhibitory of neural function, there will be an excessive hypersynchronous neuronal activity, which is the seizure. So this is the mechanism behind the seizure in general. I will give you an example of the excitatory neurotransmitter, like the glutamate. Glutamate, it will increase the post-synaptic membrane permeability of a neuron to sodium. This will lead to what? This will lead to depolarization of the membrane, like this. Here, there is influx of the sodium to the neurons. Depolarization means the decreasing of the electrical discharge between both sides. This will lead to increase the likelihood of firing of an action potential to give the nerve impulse to make a permission for it to pass. This is the excitatory neurotransmitter. The inhibitory example is the GABA, or what's called the gamma aminobutyric acid. In this function of the inhibitory, it will decrease the permeability to the sodium to pass it through the cell membrane. And instead of that, it will increase the influx of chloride into the neurons. So this will lead to what? Keep the membrane polarized. And if it is polarized, so it is stationary, it is static. This means decreasing the likelihood of firing of an action potential. So in this way, the nerve impulse will move normally by the balance between the excitatory and inhibitory function. So, what happened in a newborn? In a newborn brain, they thought it is more prone to develop the seizure because it is more prone to be deficient in the inhibitory synapses. Or the gamma aminobutyric acid has a net excitatory function in infant. Normally it is inhibitory, but because it is deficient, so the net function of it is excitatory. This is another example or other picture show when the excitatory increase the influx of the sodium and lead to depolarization, so the action potential will be passed or will be delivered. While the inhibitory, like the GABA, decrease the sodium influx, but the chloride increase, so there will be hyperpolarization, so the cell membrane will be stabilized and there will be inhibition or decrease the likelihood of action potential. So, in the immature brain especially, this is to explain why the premature baby high incidence of seizure. In the immature brain, there is relatively a high concentration of a chloride ion in the neurons. So the overall, we have the gamma has a net excitatory because it is deficient, and the chloride it is more. So this will lead to a net excitatory effect. So from this point, there will be imbalance between the excitatory and inhibitory. So the firing of action potential of hypersynchronous of group of neurons can happen, leading to development of neonatal seizure. Now we will talk about the etiology of neonatal seizure. This is very important. Why? Because it is very important to detect the cause of a neonatal seizure. Idiopathic, it is rare. So you have to go or focus on the cause. By this way, you can intervene, do the intervention properly, correctly, and you can control the prognosis. We have a lot of causes, and we put firstly is the hypoxic ischemic encephalopathy. You remember in birth asphyxia lecture, and this is most common, about 60%, and can happen in the first 24 hours. So that's why for those attending for the clinical session, the history is important, because the timing, the onset of the seizure, relating to the age of the baby, is highly suggestive of what is the cause of this neonatal seizure. The other is the intracranial hemorrhage. It is up to 15%, and it can happen along the first week, from birth up to the end of the first week. This is mostly. Maybe of any type of intracranial hemorrhage could cause seizure. Infection, CS infection, maybe meningitis, it's up to 10%, and this is usually happen in the 3 to 7 days. And if you focus on the timing, 3 to 7 days, this is meeting the definition of the late onset sepsis that happened after the 3 days. And we said from the lecture of neonatal sepsis, it is most commonly presented as neonatal, as lethargy, poor feeding, or meningitis, while the early onset mainly presented as respiratory distress and pneumonia. Hypoglycemia is an important cause, and it is about 2%. We can see it in those small for gestational age, infant of diabetic mother, and it can happen in the first 2 days of life. Other cause of metabolic, which is the hypocalcemia or hypomagnesemia, this can be seen in low birth weight, again in infant of diabetic mother, and we have 2 types. We have early onset and late onset, according to the duration or according to the timing of the onset. The hyponatremia, it is rare, and we can see it in syndrome of inappropriate ADH secretion. Other causes is the cerebral malformation or the congenital anomalies of the CNS. This is up to 7%, and this is associated with other anomalies, or it may be chromosomal abnormalities, or it may be separated, isolated. and it can begin at any time, immediately after birth or later on. And born nerve metabolism, it is an important cause, although it is rare, and this is associated with other clinical features like acidosis, disturbed level of consciousness, hepatosplenomegaly, and this is again started at the first 3 to 7 days of life, like in CRS infection. We have a cause which is the pyridoxine dependency or pyridoxine deficiency. I mean the vitamin B6. This is rare, and this is autosomal recessive disease, but it is important because in those patients that have refractory neonatal seizure, they didn't respond to treatment, specific treatment or general treatment, we should think of the pyridoxine deficiency. And if we give the patient the pyridoxine IV, the seizure will be abated, will be treated. Drug withdrawal, and especially in the Western countries, like alcohol, heroin, cocaine, and sometimes local anesthetic agents injected into the scalp of the baby accidentally during vaginal delivery also may cause it. We have a condition called the benign familial neonatal seizure. This is autosomal dominant, and this can be seen in the 3rd day of life. And this is benign from its name. And there is no cause found, or we can say idiopathic, in just about 2% of cases. But of course, we can say this is idiopathic by exclusion of all these causes. Not going directly to say it may be idiopathic, because it is very important to know the cause. Now, what are the clinical presentations of the neonatal seizure? Classically, the neonatal seizure causing a tonic-clonic movement. But in neonates, we didn't see these presentation usually. Why? Because there is incomplete cortical organization of the brain, and there is incomplete myelination of the nerve, and there is predominance of the inhibitory synapses. All these prevent development of the seizure in form of a tonic-clonic movement. So the clinical feature is can be of 4 main groups. But if we talk about the duration of the seizure, it may be 10 minutes, not more than this, not 5 minutes or 15 minutes like what happened in the seizure period. But it will be repetitive. And the median time of repetition is about 8 minutes between each seizure. So this is mean the baby may develop status epilepticus at this age, but it is not severe like that happened of older infants. Now this table shows the 4 main groups of the seizure, and the most common, which is more than 50%, it's called the septal seizure. What we mean by septal seizure? Septal, it means vague. So this is the hardest type to differentiate, to recognize by the parents from the normal behavior. And this is making the task is very difficult. It can happen in a preterm baby and even in term baby. So the septal signs may be motor and may be autonomic. The motor involves the eyes. There is a horizontal deviation of the eyes, with or without jerking. This can be seen in term baby. Or there may be a preterm baby, they may have blinking, excessive blinking of the eyes. Oral buccal, the baby may be presented with sucking movement, smacking, and the smacking in Arabic, يعني in العربية الدارجة يعني يمطق يصير الطفل يصيحوله. Chewing or thrusting of the tongue, protrusion of the tongue outside of his mouth frequently. Or there may be movement of the limbs, like in swimming movement or bicycling. While the autonomic signs, there may be tachycardia or bradycardia, and increased blood pressure and increased salivation. The clonic movement, which is the other group, it's about 25%, and this is easily to recognize because this is a jerky movement of one part of the body or more than one part. And this is primarily seen in term baby. It may be focal in one part or multifocal. What are the picture of the clonic? It is rhythmic and slow jerking. So the rate is about 2 jerk in the second. It involves the facial, the face, or extremity, or even the trunk. And the consciousness may be preserved, so the baby is conscious during the clonic movement. The least or the less common is the tonic, about just 5%, and can be seen primarily in preterm baby. It may be focal or generalized or full, but then there is sustained posturing, contraction, extension or flexion. And the least one is the myoclonic. This is rare, and this is called either generalized, multifocal, or focal. To differentiate it from the clonic, it is a rapid lightning-like, isolated single jerk. Lightning in Arabic, it's meaning البرق, يعني مثل البرق يجي على السريع ويروح. If it is repetitive, it will be of not rhythmic and, of course, rapid, not like the clonic. And it may involve the upper and lower limbs, but in the upper more than the lower limb. I now will show you this about a baby that has blinking of the eyes, deviation of the eyes, and you can see this is the clonic movement of the limbs and of the face. So this is a type of the neonatal seizure. What we can see here in this baby, look at his face. You can see the blinking of the eyes, and you can see the clonic movement. It is rhythmic and it is slow. Now of his hand and even the lower limb. And look at his face again. Now, what we can see in this baby, look at the sucking and smacking and tongue thrusts. This is subtle seizure. If you notice this baby, you may see this is a normal baby and he is just hungry, so he's doing the sucking, waiting for the feeding. But this is a subtle fit. This baby moving his hands, and look at the nurse try to hold the limb, but the movement is continuous. This is important in differentiating the seizure from other abnormal movement. Look at the movement of the hand, like swimming. Now, look at this baby, moving his hand like he is swimming, free swimming. This is again a septal. And look at his lower limbs, pedaling, bicycling movement. He is biker since birth. This is the septal fit with bicycling and the swimming movements. Now, we have this video. What is this? Clonic movement of the hand, slow rhythmic. So this is a focal clonic seizure. This is easy to differentiate. And look at the tongue thrust. Open his mouth and protrude the tongue. This is also happened with the clonic movement. What is this? This baby now is quiet, but he will develop something abnormal. Rapidly he move, like lightning, move his upper limb, and this is the myoclonus seizure. It is not repetitive, and it is rapid jerking movement. How we can differentiate between the neonatal seizure and other abnormal movement? The first is the jitteriness. Jitteriness is another abnormal movement, but it is benign, of course, and to differentiate between it and the seizure, it is stimulus sensitive. So you can stimulate the jitteriness while the seizure no. And if you hold the limb with jitteriness, it will stop, but while the seizure, as you see in the one of the clips, it will not stop. The predominant movement for the seizure, it is a clonic jerking movement, while in jitteriness, it's mainly a tremor. And there is abnormal gaze of the eye in the seizure, but there is no abnormal gaze of the eye in jitteriness. We can see here the patient with jitteriness. Look at the movement of his lower limb. It is like a tremor, and the baby is quiet, moving one limb, now moving the hand. This is a jitteriness, like a tremor, not a jerking movement. And the baby sleeping well. Now, the nurse hold the arm so the movement is stopped. While this is a tremor, it is stopped. While in the clonic movement or in the seizure, it will not stop while you are restrain the. And the baby here, there is no abnormal eye movement, and he is fully conscious. This is the jitteriness. The other differential diagnosis is the benign neonatal sleep myoclonus. And this is bilateral or unilateral, synchronous or asynchronous myoclonus. And this can happen when the baby is in active sleep and disappear when he is awake. And it is not stimulus sensitive, and the EEG are normal. And this is resolved by the age of 2 months. I will show you the benign neonatal myoclonus. The baby is sleeping quietly, and he develops the benign neonatal myoclonus. This is a rapid jerking movement, not repeat. This is happening now. And the baby will during sleep. Never happened when the baby is awake. How we approach the patient with a neonatal seizure? Of course, the history is very important. And in history, you will ask about the maternal risk factor, especially the birth asphyxia and the trauma. And you take the family history regarding the inherited disorders. If you think of the metabolism, example, should be obtained. And it's important to ask about the onset of the seizure, because most are happened during the first 48 hours, and this is mainly suggestive of the hypoxic ischemic encephalopathy, while the late onset it may be due to meningitis or benign familial seizure or even hypocalcemia. Physical examination, very important, because you will focus on the presence of other neurologic features. If there is a concurrent signs of infection, and if there is a dysmorphic feature, part of syndrome or cerebral malformation, and if there is intrauterine growth retardation. Investigation. On the top of them is to do the blood glucose. because you have to get rid the possibility of, or exclude the possibility of the hypoglycemia. You have to send for the calcium, total calcium and ionized calcium, and the electrolytes. In most cases, you may do lumbar puncture to exclude the CNS infection. The neuroimaging is very important, ultrasound, CT, or MRI, if you think of the structural diseases or intracranial bleeding or perinatal stroke. Metabolic workup is very important if you have a clinical feature by history or by examination suggestive of it. Investigation for torch infection is also important. Doing karyotyping, and toxic drug screen, and assessment of other systems if you think of the hypoxic ischemic encephalopathy or the inborn of metabolism, because it may involve the kidney, may involve the liver, or may involve other parts of the body. Of course, EEG is very important because it confirms the abnormal electrical discharge of the brain. But sometimes there is a seizure, but there is no abnormal EEG, so you have to do the prolonged EEG with video monitoring to get the correlation between the abnormalities and the clinical seizure. How we manage or how we treat the neonatal seizure? What are the aims? It's correcting the underlying physiologic and metabolic derangement. You have to know the cause, and you have to correct it. And you have to control the ongoing or recurrent seizure, because it will cause a brain injury if you didn't stop it or if you didn't prevent further one. Because so the neonatal seizures require an emergent or urgent treatment. It is one of the top emergency conditions in pediatrics is the neonatal seizure. How? By ABC. Adequate ventilation, of course, and perfusion should be ensured. And if the cause is hypoglycemia, so you have to treat immediately with a 2 mol per kg of the 10% dextrose. And then this is the bolus dose. Then to give the 6 to 8 milligram per kg per minute, or about 100 ml per kg per day to prevent the further hypoglycemia. If you think the cause is hypocalcemia, so calcium gluconate and magnesium sulfate may be given. And electrolyte abnormalities should be corrected if there is hyponatremia, which is also, although it's rare. And you have to stop the fits. We call this is the symptomatic treatment. Give anticonvulsants until you correct the cause. So the first drug of choice is the phenobarbital, luminal. Loading dose, then give the maintenance dose. But if the seizure continue after giving luminal, you have to give phenytoin. Or you have to give benzodiazepine, but lorazepam, not diazepam, because diazepam causing respiratory dysfunction, so it is contraindicated in a neonatal seizure. Sometimes you give the treatment, specific or the symptomatic treatment, but it is refractory seizure. They didn't stop. So here the trial of B6 vitamin is very important to give him, and this will be, the diagnosis will be of pyridoxine deficiency or dependency. The prognosis. The prognosis is not good. Adversically common. And in about 2/3 of the survivors, they will have long-term sequelae. The mental retardation and CP, it is common as than the epilepsy. So we didn't think that the epilepsy will follow the neonatal seizure. That's what happened in the seizure out of the neonatal period. And of course, the outcome is related to the underlying cause of the seizure. So if it is due to hypoxic ischemic encephalopathy, about 60 to 100% of them will develop sequelae in moderate to severe. While the seizure resulting from hypoglycemia, from the CNS infection, or inborn metabolism, they have a high rate of poor outcome. The good is just in that related to hypocalcemia or an isolated subdural subarachnoid hemorrhage. This is generally resolved without sequelae. Now we will talk about in the neonatal hypoglycemia specifically because it's very important. But firstly, we have to know these facts. What is the lower normal level of the blood glucose for the adult? It's about 60 to 70%. While in a newborn, of course, it will be less than this. And we have to know that the blood glucose concentration, if we compare it for the fetus of the mother, it is less than 15 milligram per deciliter of the maternal glucose. So if the mother has 80 milligram per deciliter, we think the baby may be about 65 for the fetus. Neonatal hypoglycemia. Well, we can say this baby has neonatal hypoglycemia. This is according to the age. So again, the history is very important, and you have to ask specifically, precisely about the time of delivery of the baby. Because in the first 4 hours after birth, we can say this baby has hypoglycemia if his blood sugar is less than 40. And from the first 4 hours to the first 24 hours, it is less than 45. Most of the neonates, healthy infants, they may have hypoglycemia immediately after birth, and it may reach to a level of 30 milligram per deciliter in the first 2 to 12 hours. But this is normally happened. And the spontaneous increase will happen, especially if the baby take regular feeding. So that's why it's very important to start the feeding as early as possible. Now, if the baby taking the first feeding, but his blood sugar is still less than 40, so this is regarded as hypoglycemia, regardless of the time or of the age after the birth. But in general, and by 3 hours of age, the glucose level in normal full-term infants stabilize at more than 45. So if your baby is more than 45, you are on the safe side. You are away from the hypoglycemia. What about the incidence? Hypoglycemia, it is the most common metabolic problem in newborn. And it may occur in up to 10% of healthy newborn, especially in the first 2 days of life, first 48 hours of life. And this is called a transient, and this is corrected spontaneously by taking regular feeding. So early feeding decreases the incidence. But we have conditions that increase the incidence. We can call it the risk factor: prematurity, hypothermia, hypoxia, maternal DM, maternal glucose infusion in labor, and AUGR. Actually, for those patients with or those newborn with these high risk factors, we should do the blood glucose before waiting the appearance of the signs of the neonatal hypoglycemia. Screening blood glucose is very important for those high-risk patients. Now, what are the etiologies of the neonatal hypoglycemia? To be of normal glycemia, this means a constant source of glucose. From where? From glycogenolysis and from gluconeogenesis. So the baby will be normal glycemic, or the human being in general. But to develop hypoglycemia, so either the production decrease the source, glycogenolysis, and gluconeogenesis, or there is increase of the utilization of the glucose. What makes the glucose increasing in its utilization? Of course, if there is a state of more insulin secretion. So we will take the causes in this table. We will talk about the mechanism and the disorder. So if we talk about the decreased source, inadequate glycogen storage. So this is mean decreased glycogenolysis and the gluconeogenesis. This can be seen in the inadequate substrate source. Of course, the premature baby, they didn't have the fat substrate, small for gestational age, IUGR, perinatal stress or asphyxia, or polycythemia. But sometimes the cause is increased utilization of the glucose. Normal production, but increase more than the normal in its consumption. by hyperinsulinism. Why? There is a hyperplasia of islet cell of pancreas, increasing the level of the insulin secreting, so it will utilize or consume the glucose more than the normal. The example is infant of diabetic mother, Beckwith-Wiedemann syndrome, Soto syndrome, or congenital hyperinsulinism. This is called the necidioblastosis, a tumor of the pancreas, of the islet cell of pancreas. Sometimes there is a counter-regulatory hormones to counteract the action of insulin. There is deficiency of them, like in growth hormone deficiency, like in Turner mosaicism or in hypopituitarism, or cortisol deficiency. We can see it again in hypopituitarism or in congenital adrenal hyperplasia. And it may be due to inborn nerve metabolism. Inborn nerve metabolism here, there may be a glycogen storage disease or galactosemia, and here there will be a decreased source of glucose. What are the clinical features of the neonatal hypoglycemia? Most neonates are asymptomatic. So the detection is based on the surveillance, on the screening for the at-risk infants. I said you didn't wait for the clinical feature to appear in those with risk of developing neonatal hypoglycemia. The incidence properly varies between 1 to 3 in 1,000 live birth, and it affects about 5 to 15% of IUGR infant because we say there is a decreased source of the glucose. We have two groups of clinical presentation. The first we call the neurogenic, and the other we call the neuroglycopenic. The neurogenic, it's mean the activation of the sympathetic system, so causing the non-clinical feature of hypoglycemia that can happen for diabetic patient, for adult or for pediatric, like the sweating, the pallor, temperature instability, irritability, hunger, tachycardia, and vomiting. Well, the neuroglycopenic, this is when the hypoglycemia is persistent for a longer period, so it affects on the function of the brain, and you know, the CNS is completely depending on the glucose, so this will cause CNS deprivation, and it's presented with more life-threatening presentation, like apnea, or hypotonia, seizure, and coma. And it is, if not treated or intervened with, it will cause death if the source of glucose is not established. How we diagnose it? Firstly is the screening for all infants with high risk. Blood glucose can be measured by the heel stick, by the glucometer. But if you have the level is lower than or borderline, you have to confirm the result by the sending for a lab measure of blood glucose. Infants with hypoglycemia, of course, require a glucose infusion for certain time. If it is more than 5 days, we should evaluate for the less common disorder. We should think of serious cause, like inborn metabolism or hyperinsulinemic state or deficiency of counter-regulatory hormones, I mean the growth hormone or the cortisol. But those less than 5 days, this is a transient, and this is of benign causes mainly. The management, newborn with risk factor for hypoglycemia should be offered oral feeding in the first hour, within the first hour, as early as possible. And this is even before doing blood glucose. If you provide with milk, so the hypoglycemia, if it happened, will correct it spontaneously. And of course, the aim is to maintain the blood glucose more than 45, because you remember, 45 from the age of 4 hours up to 24 hours. So, in transient hypoglycemia, what is the goal, or what is the solution? It is early, asymptomatic, and recover with early feeding, as we said. But for those causing symptoms other than seizure, يعني neurogenic presentation, give IV bolus of 200 milligram per kg or 2 ml per kg of dextrose 10%. Then In the presence of convulsion, you have to increase the bolus dose to 4 ml per kg. After that, the maintenance therapy, which is of about 8 milligram per kg per minute, or 6 to 8, to prevent the hypoglycemia. And if there is no response, you have to measure every 4 hours. If there is no response, you may increase the rate and concentration up to 12 milligram per kg per minute of dextrose 10%. And if the blood glucose is stable after 4 to 6 hours, the feeding can be initiated and the infusion can be weaned or stopped, and you can say this is a transient hypoglycemia and is corrected by giving the glucose and by initiating the feeding. While for those with persistent hypoglycemia, the infusion rate and concentration should be increased. You stop at the level of 12. Here you have to increase the level of 15 to 20% of the glucose. But if you reach to this level, you have to provide it with a central vein, not by peripheral vein. Because if you give it by the peripheral vein, it will lead to phlebitis, it will lead to thrombosis, will cause many problems. So you have to give it through central vein. But if you give about 20% of the glucose and there's no response, you have to go to the giving a hormone, the glucagon, synthetic glucagon. This is, of course, counteract the action of the insulin, and this is given over infusion in 24 hours. In cases of persistent hypoinsulinemic, hypoglycemic of infancy, like nesidioblastosis, which is a tumor of the pancreas, diazoxide is useful and can be given orally. If there is no response, you go to octreotide. So here, the management plan is upgrading. You give the management, you give the drug. If there is no response, you go to the further step. Nifedipine, which is the calcium channel blocker, it's maybe used and beneficial because it reduces the insulin secretion. And sometimes you need surgery. Subtotal pancreatectomy may be eventually indicated for those with severe persistent hyperinsulinemic hypoglycemia of the infancy. The treatment is very necessary and for a few days to weeks, but sometimes may reach to several weeks in cases of persistent, prolonged persistent. What about the prognosis? Prognosis is bad for those with, if there is a delay management of hypoglycemia, but it is good in asymptomatic patient with short duration or transient. And it's good if the therapy is prompt. But sometimes you give the prompt therapy and there is no response. Hypoglycemia recur in about 10 to 15%. So this is important after adequate therapy. CNS sequelae, seizure, it is common, and hypoglycemia may potentiate brain injury after perinatal depression also should be avoided. Now I should finish the lecture.